Switzerland. She serves. So where do we go from here? We've had what I think has been a very engaged conversation over the course of the day with several welcoming comments, as well as 3 panels so far that have explored various aspects of international health literacy. And we now need to reflect a bit upon what we've heard and comment upon that, as well as where we go from here. Our final panel of speakers will each take 10 minutes to discuss their perspectives on the future of health literacy and where we do go from here. As the other panels, I'll first introduce all of the speakers, ask you to hold your questions until they've completed their presentations. When we have Lila back in her spot, she has the cards that will remind people whether they're on time or not. We will hold all of the questions and comments until the question period at the conclusion of their comments. Now, what we will do, I will not only just take comments for the panel and questions, I will move toward the end of that period toward an open discussion of next steps and try to get as many perspectives in the conversation as we can. So you might be thinking, each one of you, as you're listening to our panel and reflecting upon what they say, you might be thinking about writing down your own conclusions and impressions and thinking about coming to that microphone during that latter part of the discussion period and making those comments for the record. I would really appreciate that. So we have 3 speakers. Dr. Ilona Kickbusch is the first speaker on this panel. She is Director of the Global Health Program at the Graduate Institute of International and Development Studies in Geneva. She is Chair of the Global Health Europe, a platform for European commitment to global health, and of the Consortium on Global Health Diplomacy. In Switzerland, she serves on the executive board of the, I can't pronounce this, Carium Foundation, and is the chairperson of the World Demography and Aging Congress, St. Gallen. She is senior advisor to the regional director of WHO, Regional Office for Europe. She advises organizations, government agencies, and the private sector on policies and strategies to promote health at the national, European, and international levels. She has published widely and is a member of a number of advisory boards in both the academic and health policy arena. Her key areas of interest are health and all policies, and the health survey, the health society, and health literacy, global health governance, and global health diplomacy. Our second speaker on this panel, Dr. Juergen Pelikan, is a trained sociologist and psychologist at the universities of Berlin, Hamburg, Vienna, LSE, and Columbia University, New York City. He specializes in teaching and research in sociological systems theory, health promotion and health literacy, sociology of health and healthcare, and sociology of organizations, with a focus on organizational change, based in Vienna, Austria. In the last 2 decades, he has focused his basic and applied research on reform of healthcare and development of health promotion in theory and practice. He has conducted health literacy research since 2001 as the project director of the European Foundation on Migrant-Friendly Hospitals, whose 3 sub-projects had a strong focus on health literacy. Following this project, he was involved in workshops on health literacy at the European Health Forum in Gastein, Austria, and the European conferences on public health, and belonged to a group of European researchers initiating the European Health Literacy Survey. Currently, he also is directing the analysis for a specific report on health literacy in Austria and its regions, and additional Austrian study on health literacy of 15-year-old adolescents. He is a member of the Board of Trustees of the IUHPAE. I wonder what that means. Please.
It was explained today by Diane Levin.
Okay.
It's the International Union of Health Promotion and Education.
Okay, I don't recognize that acronym, but thank you for making that association. Okay, within that organization, he is a member of its board of directors, and he's active in health literacy work. Finally, we have not Dr. Donald, but Dr. Don Nutbeam, he corrects me, is Vice Chancellor of the University of Southampton, a position he has held since 2009. His career has spanned positions in universities, government, health services, and an independent research institute. From 2003-09, he was in senior academic roles in the University of Sydney, Australia, and prior to this, he was head of public health in the UK Department of Health. His research interests have included social and behavioral interventions in schools and communities, as well as studies of health literacy and adolescent health behavior. He is an author of more than 100 publications in peer-reviewed journals, as well as 2 popular public health textbooks. He remains research active with, within the constraints of his current role through funded projects and Ph.D. student supervision. Professor Nutbeam has substantial international experience in both developing and developed countries, working as an advisor and a consultant for the World Health Organization over a 20-year period, and as a consultant and team leader in projects for the World Bank. I thank you all for joining us today, and Ilona, you have the microphone, and I believe you're going to speak without slides.
Well, good afternoon. I'm delighted to be here, and in meeting some people, I was thinking about being here in the United States at Yale University 10, 15 years ago, and working and meeting with people like Scott and with Ruth, and trying to think how we could bring further the dialogue between a more, in quotes, European perspective on health promotion and health literacy, and the way it was being discussed here in the United States. And when I left Yale to go back to Europe, it was one of my goals to actually strengthen health literacy in Europe and be able to actually have data to see whether the levels of health literacy in Europe were better or worse or the same as they were in the United States. And as you heard, in joining forces, we were successful to actually get the European Health Literacy Survey. But I think it's important to keep in mind for the discussion how we want to move forward is why did we push for health literacy in general and the European Health Literacy Survey in particular. And it was because we wanted an outcome. We wanted an outcome measure at population health level that would indicate the composite impact of health promotion measures. We wanted to move away from just having a program by program by program success or failure rate. We wanted to be able to show at the aggregate population level how health literate is a population, and from that deduct how well a society has been doing in terms of investment in skills and capacity of its population to deal with health issues. That is, I guess, the key point I want to bring across also for the future activities, is we wanted a composite, in a sense, political figure with which one could argue, with which one could talk to politicians, to other decision makers, and say, you know, these are the data, this is the evidence, what difference does it make? Are you fulfilling your responsibilities as a state, as an employer, as a society? And we have that now in Europe, and the figure we have is just as ominous as the very same figure here in the United States, 47%. 47% of the population do not have enough health literacy in Europe. And I guess from those ominous 47% here in the US, one would probably also say that that is the part of your population that has a low health literacy. And our goal, and partly we have achieved it, and Christine has alluded to it, is if you have such figures, you start to get attention. And we, a couple of weeks ago, got the attention of all the Austrian media at a big press conference because, of course, the media likes crises and problems, because Austria has a low level of health literacy compared to other European countries. That was news. That was politically a question, an issue. And as Christine has indicated to you, it was one of the reasons why we find health literacy as a political goal in Austria now. It is not acceptable. It is not acceptable for a European welfare state to have such low levels of health literacy, particularly if they are low in comparison to others. So I think this question of, how do we see health literacy? Do we, in quotes, only measure it at the individual level, at the community level, or do we measure it as at the population level to be able to say this is a politically critical figure and it talks to us about where we need to invest in our society? That also means, and with this I reflect some of the discussions we had during the day, it also means it doesn't so much matter whether we all agree on the same definition of health literacy. I think, let's continue to fight about that. But we need to be clear when we communicate with decision makers, what are the dimensions of health literacy? What is it we want to tackle? And I would put to you that it is 4 things we want to tackle and 4 things that we can put across to decision makers. One is the fact that we need to equip people with the possibility to make healthy choices in an environment that is basically detrimental to health. I think that is an issue we need to bring across. Some people call this a toxic environment. And we need to be able to show how that is influenced or not through higher health literacy. We need to be able to indicate how people get the skills and whether they have the skills to self-manage their health behaviors and to live with chronic disease and support their families with coping. That is, how can they be part of a co-production of health? And if we speak of people-centered health systems, that's what we're talking about. The third is, do we give them the skills to navigate increasingly complex healthcare systems also that are not only complex but intransparent and undemocratic? And again, do we do this? And we can measure whether we do it or not. And finally, the issue of, do we give people the skills to communicate with health professionals? So if we take those 4 dimensions, then health literacy is about measuring how well equipped people are to do this, work in those 4 dimensions. But it is, and I really, really want to underline that, and it takes up Rima's point that she made in the discussion earlier, are we as a society equipping people and supporting citizens in the pursuit of health? And I would put to you that it is unacceptable, I'd like to underline that, it is unacceptable in a modern democracy that 47% of a population do not have the skills and that we do not make available the environment for them to actually use the healthcare system adequately and to access health adequately. And that also means if we're looking at health literacy, we're not just looking at healthcare systems, we're looking at every single supermarket, we're looking at labeling, we're looking at all those factors, and we're looking at a range of determinants of health. We've said, there are social determinants of health, but we are looking at the political and the commercial determinants of health that actually refrain people from being able to access their citizens' rights and their patient rights. And I would put to you that health literacy is a debate about human rights, patients' rights, and citizens' rights. And we also have to frame it in that context if we want to build alliances. So health literacy, as some people have said, a determinant of health, an important one, and data seem to start indicating that, but also health literacy at the interface of other determinants of health. I'd like to use my last minute just to give you some indications where I think we should take the health literacy debate if it is a policy and a political debate. We have to integrate it into the key global debates. We heard about the Decade of Literacy, the NCD Challenge, and particularly the MDG debate on MDG 15, and the inequality debate. Health literacy is inextricably linked to the debate on health inequality. Secondly, we really have to strengthen the link between adult literacy and health literacy. And if we build some kind of alliance, we have to target the OECD to move forward with strengthening the health literacy dimensions of the surveys that they conduct. Thirdly, and I was thrilled to hear it mentioned by one of the participants, we should begin an initiative with the World Economic Forum, possibly with the ITU and WHO, to actually move forward this whole movement of mHealth and health literacy in developing countries. Here I think we could continue with cross-national roundtables, particularly involving the BRICS and the African countries. And I think this is a policy and a political agenda, it's both policy and political. I think as a family of health literacy people, we should start developing policy briefs with arguments about the economic argument for health literacy, the costs of low health literacy, the unacceptability of excluding 47% of the population, the contribution of health literacy to achieving healthy life years, making health literacy part of the health quality agenda, as we've heard, and health literacy obviously as being central to a patient-centered healthcare system. Finally, I'd like to say we need to address the health literacy of key decision makers. What's the health literacy of journalists? What's the health literacy of parliamentarians? What's the health literacy of mayors and business leaders? And I think if we had a focused initiative of trying with such policy briefs to bring that forward in that way, I think it would be critical. And we really need to work with patients and citizens. I've heard very, very little today about how patients and citizens exchange health information with each other. We saw the Patients Like Me platform, etc. These things are expanding rapidly, and we should be supporting them and taking it forward. To end, I'd like to quote Sheena Iyengar here from Columbia University, who's written a fantastic book that I would urge all of you to read. It's called The Art of Choosing. And from that book, I'd like to leave you with a quote. She says, "We wish to see our lives as offering us choices and the potential for control, even in the most dismal of circumstances." I think with that she echoes what Amartya Sen says in Development and Freedom, and she says you need to have both. You need to have choice plus control. That's empowerment. What our modern societies often offer is choice without control, without knowledge, without skills, and I think that is irresponsible. Thank you very much.
Thank you so much for inviting me. It's a real privilege and a pleasure to have the opportunity here to offer you my view on where to go from here, next steps for health literacy. I was not so wise as Ilona was. I prepared slides, and so I have to talk with you about what I was thinking on Friday concerning these issues, but you will see much of what I thought on Friday I can still offer you today after we had this wonderful day of these many very, very interesting discussions and introductions we had here. I have to warn you before about my déformation professionnelle. You see, I spent 2 decades trying to reorient health services by building up the health promoting hospitals network for WHO. I did the migrant-friendly hospitals project, and in the last years I was very much involved in measuring population health literacy. Well, health literacy is a very attractive concept. It brought us together today. Many, many people are jumping on it. One has the feeling, and many people are using it for their purpose. And there are some interesting characteristics why this concept is, as Woodman would say, a valuable concept. Well, health literacy can be defined, but there are still limited consensus and definitions, and I know within our community there's a debate if this is a good or a bad thing. But health literacy, and I think that is one of the specific characteristics of it, and Ilona was very much arguing that just before, health literacy can be measured. But again, by a number of instruments differing in scope, content, and psychometric qualities, and it can be measured in different ways for general populations, and there are rather few studies, one has to say. It can be measured for specific vulnerable groups, especially patients, and there we have a lot of studies. And it can be measured for systems, organizations, services, products, and there again we have very few studies. The interesting thing about measuring is we can compare cross-sectionally and longitudinally, which is very important, I think, especially for practice and for politics, that we measure longitudinally and that we see what are the effects of the political and health promotion measures, or the health policy measures we have used. And of course, it's a determinant of health, I think, and it's a specific determinant of health. It's one which can be intervened or taken into account, and that are quite 2 different kinds of strategies to go about it. On 2 levels, improving competences of people and decreasing demands of systems, organizations, services, products. Again, the last one is much less explored yet. Second, there's available, partly contradictory as we know, and fragmented knowledge on distributions of health literacy and associations with social causes, with conditions, with determinants of lower health literacy mostly, about vulnerable groups with lower health literacy, and of health-relevant consequences, again, mostly of lower health literacy for health behavior, use of services, and for costs. You see from the HLSAU study, we learned, I think, 4 things. The first one is health literacy is not only complex, but because it's complex, it's very diverse. Therefore, you see we have to measure in every country, because what we learned, there are differences between countries, and not only for averages or distributions or standard deviations, but there are quite strong differences concerning associations. You saw the one slide of Christine. There are countries where there is a relationship to age, and there are countries where there is no relationship to age. And we can show that for many other social indicators that there are really big differences, partly on a matter from 1 to 4 concerning beta coefficients in multivariate regression analysis, for example. Another thing, what we learned, of course, here, that is not just a characteristic of our measure. The same we found for the NVS test, which we had included in our questionnaire, and the same we found for self-assessed health. Therefore, I would like to concentrate on just 4 or maybe even 3 main deficits or challenges which I see for research practice and health policy from a public health perspective. First, what Ilona was talking about, we need population measures, we need them continuously, we need them for a comprehensive form of measure, we need them economically, so therefore we need short forms, and we have to be able to make comparisons and benchmarking. Second, you see, I really love the concept which has been quoted today so often by Razan and Ruth Parker. Health literacy is about personal competences and about situational demands. It's a relational concept, it's a contextual concept, but you see there's a real imbalance. Still, we have said, and I very much liked that we heard today that we should invest more in organizational change and development, and I was very much impressed by what is going on in Australia, and of course the work Rimarat did and this institute did concerning health literate organization. But still, we don't have many measures for the health. We have characteristics, but we don't have many measures for the health literate organization. And we don't have many studies measuring that. And I think if we will take this concept seriously, we have to measure on both sides, on populations and on the system side. But of course, if we want to improve systems, only measuring, of course, is very important for arguing, especially for politics. But at the same time, as we can learn again from Australia today, where they were talking that it's important that users or clients or patients are included in planning and governance of the systems. And you see in the country in Europe where our data were best, who have the highest health literacy, that is the Netherlands. And the Netherlands have a very good developed system where patient representatives are included at all levels of the healthcare system. And that's, of course, an interesting way of making the healthcare services more health literate, because the users have a direct say in planning and in governance of these services. I will say a little bit more about the studies we need, and the last point, because I think that is very important in our context. You see, what we need, I think, is a much more systematic and sustainable integration of health literacy in healthcare services. Till now, usually, we were just looking at low health literacy, and we were measuring it, or we were trying how to deal with patients with low literacy. But from a public health perspective, the real goal has to be we have to use our healthcare services to improve health literacy, and to improve it not only from the low literate patients, but from every patient. Every patient, you see, it's a teachable moment, it's a window of opportunity. We really have to have a healthcare system. When you have had contact to it, you have to have after that better health literacy. You know this NHS strategy, which is now make every contact count. Where do we go from here? You see, you might think that's a little bit visionary, but I'm taking up here from Ilona Kickbusch and Razan and others. You see, from a public health perspective, we need health literacy as a health index for societies. We need it as a measurement of health development. And that we cannot just do by scattered research and practice efforts, but we need much more integrated approaches here. And I think there are some models of good practice where we can learn from sustainable international research. Ilona already mentioned OECD. We know there was the EALS studies, there was the AALL studies. There's a PISA study, which is very effective and very important for school policy. or the new program of international assessment of competencies. That's the one example. The other example is WHO's Health Behavior in School-Age Children study, which was developing from 5 participating countries in 1983 to 40 in 2009. And what we really need here is not just to have networks, but to have an international project like that. It has to be an open project. It can start with few countries, and it has to be open too in the way that we need core measurements there, and every national society must have the possibility to add certain specific things to it. And I think that was part of the characteristics which made these projects very flexible enough and sustainable at the same time. And of course, if we want it as a public health measure, in the end, what really is needed that health literacy is included in official health statistics and in health reporting. Well, what can be next steps to these goals? Of course, there are difficult goals to have this continuous population measurement, to put much more stress on measurement of systems. What I think we should do here, we really have to start, and here are so many people who can do that very well, with agenda setting, alliance building, and allocation of resources. To go into this direction, we should form international working groups with clear goals, timeframes, and resources to start and prepare some open international projects. And I think concerning these projects, especially for the project where we will which is about comparative population studies using these instruments, we need very strong leadership. Best would be to have a leadership combined by OECD and WHO. That, I think, would really, concerning our topic, the best kind of leadership. And of course, we have to try to convince these people. But concerning this other goal, which I think is so important, to really reorienting health services towards health literacy, IOM, our host here, really can have very good leadership concerning that, and maybe from Europe, Careum Foundation, where Ilona Kickbusch is involved, could help so that we could have a American, European initiative to go into this direction and to make that more, to have a more radical mission and aim here. And I would like to invite all of you to help that we can try to tackle these 3 very demanding, but I think very important goals, and to go into this direction. Thank you so much for your attention.
Thank you.
Well, thank you very much to the organisers for the invitation to join you today, and to George for keeping us mostly to time, and to acknowledge the extraordinary leadership that the IOM and the Roundtable have provided in moving health literacy along over the past decade. It's been a long journey. Now, I have to say I greatly enjoyed Nicola's presentation about the state of health literacy in one part of the Australian healthcare system, and was deeply impressed to read all that Andrew had dug up about what was going on in Australia. By volume, Australia was a major contributor to your review by all accounts. But I want to take you back in history, because in 1991, more than 20 years ago, I and a group of colleagues at the University of Sydney were commissioned by the Australian government at the time to review and then revise Australia's national health goals and targets as they existed at the time. And over an 18-month period, we worked on what we thought was a quite visionary and rather radical set of proposals for health goals and targets in Australia that included the conventional goals and targets relating to preventable mortality and morbidity, and healthy lifestyles and reducing health risks, in the population, but also included proposals for 2 new major areas of national health goals and targets. Those were for the promotion of healthy environments, and a whole chapter of the report on health literacy. And just for historical interest, you may see there that we defined health literacy more than 20 years ago as the ability to gain access, understand, and use information in ways that promote and maintain good health, reassuring that 20 years on we're still broadly in the same territory. Secondly, in terms of the 3 goals for health literacy that we promoted at that time, the first was to very clearly align the improving health literacy in the population was fundamentally dependent upon levels of literacy in the population. So our first goal was to align health to literacy in the population. And then 2 more broadly based goals that were largely about using literacy, using health literacy in this case, to enable people, in one case, to make informed choices about their health, and in the other case, to bring about changes in the environments that shape their health. Any of this familiar? 20 years on? So it was published to great acclaim, I have to say, and launched by the then Australian Health Minister, Brian Howe. And I have to say, as a publication, it remains among my most highly cited publications. Regrettably, a week after the report was launched, the government of the day announced that there would be an election. The Health Minister, Brian Howe, didn't survive the election, and neither did our recommendations for a radical change to the nation's health goals and targets. And indeed, what happened was a progressive narrowing of those national goals and targets to focus only on preventable mortality and morbidity. And health literacy basically disappeared without a trace in terms of public discourse in Australia for about a decade, basically, before it began to re-emerge again in the early 2000s. I say all of that because it provides context for how wonderful it was to read Andrew's report of what's going on in the world. I'm familiar with what's happening in the United States, and it was great to see how health literacy has taken off around the world. And in terms of our appraisal of where we are now, well, I have 2 immediate emotions. Firstly, I'm genuinely delighted to see that health literacy has taken off around the globe, that we have, I think, a far better appreciation of the nature of the relationship between literacy and health. I think we, as you'll seen during the course of the day, a much more sophisticated understanding of the importance of informed choice, of patient engagement, of community engagement, and of the role that literacy and health literacy can play in empowering people to do things that will improve their health. On the other hand, I have to say, I'm also rather worried. The frank truth is health literacy has become rather fashionable. It's become rather politically fashionable. And often I've seen it represented in ways that personally I don't recognise. And as a panacea, as it said here, for many of the ills and ambitions that we have for the healthcare system. Now, my concern about this is that this is exacerbating what we've already seen as some conceptual confusion. And in this sense, I'm worried, although enthusiastic, I'm worried that this conceptual confusion might actually hold back the future advancement of the science and the translation of our science into policy and practice. Now, where do we go from here? Well, I think we need to do 3 things. Firstly, we need to sort out some conceptual confusion and some of the potentially competing paradigms. I certainly accept there's an alternative view that we should let 1,000 flowers bloom, but as I say, there are some real risks associated with this. I think we already know quite a bit and clearly are learning more from outstanding studies like the European Survey that we've heard about today. So we need to put into practice what we already know. This is about knowledge transfer as well as new knowledge generation. And then finally, and I think again Juergen and others have made a very clear case that we need to more systematically and more collaboratively address the challenge of measurement. And I might say, I prepared these slides before I knew what Juergen was going to say, but the conclusion is exactly the same. Now, I think we only got 10 minutes, and I have about another 25 slides. So what I'm going to do, those slides are going to be available and people can refer to them. I'd like to talk about some issues relating to conceptual confusion. I was going to talk a bit more about what I think health literacy is, as opposed to what it's not. But I'll skip that bit. You can read about it if you're interested, and go on to some concluding remarks. It's always a mistake to ask me to speak for 10 minutes, by the way. I am actually genetically incapable of doing so, but I will do my best. So, what about the conceptual confusion? Now, I want to be a little bit provocative here. This is the final session. This is a good time to start having some debate. So I'm going to propose to you that health literacy is not an action. And I personally get frustrated when I hear health literacy used in phrases as though it's something we do. In my view, health literacy is an outcome. Ilona described it earlier as one way of describing the kind of outcome that we're looking for from health promotion interventions. It's either an outcome or it's a status measurement, as is literacy. We don't do literacy. You use literacy as a measure of outcome or a measure of status. What we do is we educate and we communicate. And I think it's really important to get that differentiation sorted out. Health literacy, just like literacy itself, is an outcome. It's a status measure. It's not an action. Education and communication are actions. There's also been some conceptual confusion about the relationship between language and literacy. Occasionally, a confusion that because somebody doesn't speak the predominant language of a country or a community, then they have a health literacy problem. Actually, what they have is a language problem. And the solution to this, and they may well be very literate in the language that they speak at home, highly literate in the language that they speak at home, but not good at the predominant language in their community or their country. Now, it's translation and interpretation services are what's needed here. This is not a health literacy problem. It's a language problem. The third conceptual confusion that I would observe is that there is this fundamental relationship between literacy and health. And I again, I often see the two conflated. And I don't think we should. Some people are literate and some people are not literate. And then there are relative measures of literacy. Some are more literate than others. And what we know is that on a population basis, there is a direct relationship between literacy and health status. And it's one of the reasons why I indicated earlier that 20 years ago, we very clearly recognized that we needed to link our interest in health literacy to improving general literacy in the population, but we shouldn't confuse the two. One is a social determinant, literacy is a social determinant of health. Then, I suppose, where I'd like to finish this little bit about conceptual confusion is a slightly more provocative proposal, and that is that there is actually a difference between what I've referred to here as health-related literacy and a distinct concept of health literacy. And the health-related literacy means that people who enter, for example, the healthcare system with low general literacy will often have problems with the system and problems in responding to what the system might demand of it. And this is more to do with the impact that low literacy may have on an individual's ability to engage successfully with the healthcare system. It's a deficit to do with general literacy rather than a distinct and positive concept of health literacy. And here the response needs to be, well, you need to identify individuals who have low general literacy, and we need to both modify the way we communicate with them and the environment in which we expect them to interact with our health decision making. And where that leaves me is proposing health literacy as a distinctive domain of general literacy that is both content and context specific. You can assess it in both absolute terms or in relative terms, and importantly, it can be built and improved through educational interventions across the lifespan and as we have heard regularly, can obviously be supported through a supportive environment. Now I'm going to skip the rest of this lot, but for those of you who are interested, the slides will be online, and it's a discussion about what can we learn about health literacy by an examination of health literacy. And the point is that literacy can be examined in relative terms. There are different skills levels, and health literacy can be considered in the same way. And I make the point that literacy is both content and content specific. So there are many forms of literacy, many different literacies, and health literacy can be seen as one of those, and that health literacy in and of itself is contextualized by age and stage of life. And again, we've heard that in the last few days. And again, I'll encourage you, if you're interested, to have a look at that. So where does all that leave us? Firstly, in terms of what we know, and I have to say, again, great credit to the Institute of Medicine for all of the work that it and other organisations have done in order to capture what we know about health literacy. And where we are in our science is we have good evidence derived from research in clinical settings which have linked poor health-related literacy with a range of clinical outcomes. We've also learned from outstanding work done by a number of individuals, particularly in the US, that the rapid assessment of health literacy is feasible in normal clinical settings. And there have been some very good and increasing number of intervention trials in clinical settings to show both the potential effectiveness and cost savings that can come from interventions which take account of differences in health-related literacy. Outside of the clinical setting, there's promising, but as yet largely undeveloped intervention research in settings such as schools, in adult education, and in E, and now I've learned in M, learning. Where do we go to here from research? Well, I think you heard a great response from Juergen in relation to that, and I can only agree with what he said. But for me, the focus has to be on intervention as much as anything else, and I think we need to continue to broaden and test different types of intervention designed to build health literacy in a population. I think there is great potential, and we heard that this morning and throughout the day, for E and M health initiatives. And importantly, we've heard some great examples, both from Europe and also, I'm aware, in Australia, of measures of health literacy, and in the US, sorry, particularly I'm thinking about the HALS and some of the other measures that have been developed that incorporate a much wider set of skills and capabilities. In terms of where we go from here in clinical policy and practice, well, I'm not going to rehearse all of this. I think you're all aware. We need to promote understanding among clinicians. We actually need to recognise that it requires different forms of educational and communication methods that are often common in clinical practice. And as I think you've heard on many occasions, we've got to have service management and organisation that's literacy sensitive. And finally, where to from here in public health policy and practice? Again, I make the point, this fundamental relationship between general literacy and health literacy in the population, something we've heard very little about today, and that is the really important role that school health education can play in building a foundation for future health literacy. The need for us to exploit where I think there are real opportunities for educational interventions in healthcare, for example, antenatal education, patient education for chronic disease management. And finally, we've heard a couple of examples of opportunities for health literacy through adult educations and skills development programs. Thank you.
Thank you very much. So questions and comments for this panel. Bernard.
I just want to make some comments since we were challenged to do so, so I will meet the challenge. First, I think before I get to the present panel, I think today was a wonderful day, and in reflecting on it, I think that the problem of the issues of health literacy obviously are international, but also there's a huge amount of commonality that we all have, and we're sort of all in it together. It is true that there may be different associations in different countries with some risk factors, but I think overall what we heard today on the international scene was what we talk about all the time in the United States. So this is an opportunity to collaborate and use the strength of our combined knowledge to make a dent in this problem. Specifically, you know, we also know that there are two major issues, but one of them really, and that's our major responsibility, is to decrease the health literacy load that the health system puts on patients and people. And I think that should be a focus of a follow-up from this meeting. I also think that we often get overwhelmed with all the tasks that we have to do in health literacy, and I think some of the themes that came out today are the chance and the need to perhaps focus and choose areas that we think will be most productive, both in decreasing load and designing interventions to help people get better outcomes that are related to the issues of health literacy. Second, I wanted to just reflect on some of the points that were made by this panel, which I think were absolutely powerful. One is that health literacy, as Professor Kickbusch said, is an issue of justice, of health inequality, and that I think there is a huge focus, at least in the United States, and I presume in the European countries and other countries, on the issues of health disparity or health inequality. And we have been trying to get health literacy to be connected to that inequality and to stick to make that an issue that should be dealt with if we're going to be solving the problem of health inequality. And I don't think it has really stuck yet. So I do think that that's a powerful thought. We have to figure out how to make that connection seen and believed by the powers that be. I also think that the issues that Professor Pelikan brought up about using measures, for example, through the OECD, that I think the measures that the OECD does in other areas have been very powerful in moving the agenda forward. And I just want to second the fact that if we can make health literacy measures and also some measure, which we don't have a good one yet, of the burden of health literacy that's put on people, and use that to measure across countries, that will be a very powerful thing to do. Finally, just a few comments on research and what we don't know. There was a very intriguing statements made about how many people have cell phones or smartphones, and mHealth, a new kind of concept, which seems like a powerful way of reaching huge numbers of people at a public health level. But the only thing I would say is we really don't know if it works. There's very little literature out there that shows that actually texting somebody makes a difference in their life. There are some, and I'm not putting it down because it's clearly a way of reaching huge numbers of people across the world. But that certainly seems to be an area that we need to focus on getting some more information on to see if this really works or it's just something that sounds nice and doesn't work. I think, well, there are some other areas that I want to bring up. One is medication labeling. I think there have been some comments, but there's a huge problem with medication errors and the use of medication. And there is research on medication labeling, but I think that's something that perhaps as an international community we could focus on as well.
Yeah, we didn't hear a lot about that today, and that has been the focus of at least one meeting of the Roundtable. Commentary in response to that, or no? Okay. Let's go to the back. Patrick.
Thank you. Pat McGarry, a Roundtable member, and I want to thank not only the Planning Committee, but also the sitting panel and all the presenters today from traveling great distances to enlighten us with the health literacy efforts around the world. So thank you very much. I was struck by Andrew's paper when I read it about in South Africa, there was a rural asthma patient who didn't realize, well, she actually said, or he says, I know goats or sheep and cows have lungs, but I didn't know that I had them. This is basically not literacy or illiteracy, it's ignorance. And to me, it's unacceptable that somebody in this day and age doesn't even know they have a set of lungs. As a tobacco advocate, I take great umbrage to that. And also, I want to commend Dr. Nutbeam for finally bringing up school health education and comprehensive health education, including school-based clinics. Most of our discussion today, we've talked about the problems of health literacy, but I feel a real solution to ameliorate the health literacy issue is to have comprehensive school health education. And I'd just like to close my comments with citing, if I can find it. Actually, there was a IOM report in 1999 that talked about school and health, and it talked about how important it is for not only the health, but the social and cognitive development of students. So I think we should kind of look back at our literature like we looked at Dr. Nutbeam's study from 20-odd years ago. So thank you very much.
Thank you for those comments, Patrick. Scott, and then Will. Oh, I'm sorry. Were you first? I can't. One thing is that I don't have very good depth perception, so I can't tell who's standing in front of who's.
I'm also kind of short.
No, that's totally my fault. I apologize. Please,
Not a
please
problem.
Proceed.
Good afternoon, everyone. My name is Lisa Kahn Kapadia. I'm a health literacy program manager at Community Healthcare Network, and I enjoyed all of the presentations today, but my work that I do, I especially have enjoyed the last three panelists because you bring up a very good point about the need for research on what companies are doing internally and what healthcare is doing internally to integrate health literacy into their organization. That's what my job is to change the culture of our network of federally qualified healthcare centers to become a health literate organization. We've settled on definitions of health literacy. We have moved forward with infrastructure such as a health literacy task force, a patient communications committee that reviews information. We have clinical and non-clinical staff involved. We have a lot of great things. And as I look for funding to move forward and do more research, the problem with my innovative work and with how my company is really taking responsibility for health literacy and from the provider perspective is there's not funding streams that fund the type of research that we're looking to do, which is organizational change. And one thing that I think the IOM and those that are looking for policy change, perhaps speaking to those that fund research to see what other things could be funded that are not already being funded to explore, because part of the problem is we're all looking for grants and different money sources to be able to do the work that we do. And I think that would be a key area to help us all move forward in health literacy and expanding the research beyond continuing to diagnose that there is a problem that we need to solve.
Thank you again for that comment. I think we'll go to Will, and then I saw Cindy, and then I think Scott, you're next.
My comment is really brief, and Ilona, is really directed to you. I was absolutely pleased to hear this whole focus. I think it's really been a thematic core throughout this day, and that is getting back to health literacy as indeed a human right, elevating to the point where it really becomes an unassailable right, codifying it into our policies at the highest level. I just wrote a review on a book by Barakachia on rights-based public health, and really tried to highlight that issue even more so. But I just think we need to do a little bit better job of cementing that relationship between health literacy and human rights, and as a consequence, I think there will we'll be able to provide a little bit more sustainability in our effort. Otherwise, I mean, certainly based on comments by Juergen and Donald, I mean, we'll have this conceptual difficulty in identifying what's health literacy and what's not, and we won't be able to really get the requisite resources to have a implementation that will be sustainable. So I'm hoping that we can move this issue more so into the realm of public health, and just so for the audience, you should all know that we actually we will have a focus on health literacy and public health, and I'm hoping that this will then be a nice segue into that discussion.
Thank you, Will. Scott?
Thanks, Will. I appreciated it.
Oh, I'm sorry. I was going to go to Cindy. I apologize. Scott, you go, and then Rima, and then Cindy.
Thanks. First, I thank Will for bridging the public health piece, and I want to especially thank the panelists, but also everyone today. But most importantly, Don, you reminded me, I used to say that all of what I learned in health literacy was first a European concept, and you were a European in Australia in '93. So a lot of the work that you continue to do really has helped groundswell in our work here. And I think it was the first time with both you and Ilona pushing health literacy with Health Promotion International and the WHO Mexico City meeting that really helped put many of these ideas forward. Now where I think we are today is exciting, that hopefully we're not going to continue to have which definition is best, which way of research do we need to go, what is the area, but where can we make some impact. And I think this last panel spoke quite a bit about some areas of impact that could be long-standing and sustainable. And my question, I think, ties in with, Juergen, you said some very good ideas of some policy briefs, some specific areas where we can help make a difference, particularly the OECD. I mean, I've been going to an OECD meeting, and I'm happy to bring this up again every year. I go to the Economics of Prevention meeting, and they still ask me for they want numbers. The 47% doesn't mean anything unless we can translate that into lost valleys or something of that nature. So I don't know if that's something that might be worth considering. But a policy brief to bring the OECD up to speed, I think, would be terrific. The second piece, the World Economic Forum that Ilona mentioned, if you look at the World Economic Forum documents, which includes us, we're on this Global Agenda Council that has academics and OECD, we have the words health literacy, but we can't get it to another level. So hopefully there's more of an opportunity, again, for whether they're policy briefs, advocacy pieces, or activities that can stay. And I think the idea of an index is one that still fits well, and this could be both OECD. You can certainly do DHS if you want developing countries. There's lots of places to move in these areas, but as much as we say that from an academic standpoint, we also need an advocacy standpoint. So our ambassadors to OECD as countries, or our business sector, which also has a seat at the table, or others. Trade unions are there, as you know. So I think we have to try to think, okay, how do we get this to the next level? Which just bridges to the final point that I want to still make the case for mHealth. I know we've heard that a lot, and although respectful of Bernard, I've been arguing the need for better communication. When I started the Journal of Health Communication 18 years ago, people didn't even think it was a field. And now we see burgeoning monthly publication in that regard. I think mHealth is sort of the next frontier, and I think we can get it right if we do it with health literacy. And I'm just going to propose again that I mentioned we have a unique public-private partnership with Johnson & Johnson in Norway. We co-chair this United Nations Innovation Working Group. Stephen referenced it, that we're actually the so-called innovation engine for some of the UN programs. We have an mHealth and e-health working groups that anybody can participate in. The kind of thinking that I've heard here today, the final panel, I think, in all respect, is quite intriguing and motivating. So I would hope that some of you or your people like you can engage. But as many of us that can engage and articulate health literacy engagement in these new health communication channels that we can only dream of today, I think will make a huge difference. So that would be my call, and I appreciate, we've worked a long time to try to get this meeting. We want, whether we call it international or global, and frankly, we've missed a couple of continents that we would like to have a little bit stronger. So I think the call is next time, or another time, we have other continents and other countries that are here, and maybe have other regional meetings. But in the end, if what I've heard about the global groups, if we could continue this momentum, and I can say from our participation, both in the academic and private sector side, and the work of the IOM and the Roundtable, we hope to continue it. So thank you all very much for the enlightenment, and we hope to have your continued engagement.
So before I go to Rima, any comments from the panel on what we've heard so far? I'm impressed with the thundering agreement and the, but not surprised. I think we've had some very eloquent commentary from these panelists.
Can I just
sure, go ahead and try to pick a fight there, Don.
Because otherwise it'll get boring if we don't have a decent argument at some stage. But I mean, I'm with you all the way, Scott, wherever Scott is. I've lost him now. And with Ilona, of course, and both of you know me well enough to know that I really mean this. I am with you all the way in terms of trying to engage successfully with a range of political processes. The critical thing from my point of view is that in the end you will get found out if you don't have a decent scientific base. That there's only so far you can get with the rhetoric. And one of the things I was trying to, and I'm not suggesting that you are only talking on rhetoric. I'm simply saying we have to do two things, at least two things at once. One is be good advocates, and the other is continue to advance and strengthen the science. And I suppose the point I was trying to make is that if we have lots and lots of things going on, it's harder to advance the science. And finding the right balance between that and our desire to advocate, I think, is a real balancing act in the future.
Ilona?
Well, just to add to that, the major part of the balance is, of course, that you need to advocate in order to get funding, to get the scientific base. So, you sort of get into a circle, and you're just, if you're in a new area of work, that's what you do. And I believe that in public health you do have to take some risks. And just as people who did microbiological research and try to find out, what was the origin of cholera, and they were wrong for a whole number of times, and then they were right. And I think partly we have also lost that courage in public health to say, we have to make some good guesses and we have to move forward, and probably in this day and age more rapidly, if we're willing to invest in the research side of this, we can get results much better than we could 100 or 150 years ago. So I do think it's that balance of being able to advocate here is a critical issue. We have enough indication, we have exemplars, as Thomas Kuhn would say, in relation to a paradigm shift. We have some exemplars. We now need to move forward. We need to have more funding in order to be able to strengthen the evidence base of what we hope to do, so that, first principle, we do no harm. And as the person who started the advocacy for the European Health Literacy Survey, I could tell you a lot of stories about that. And it took 3 years and a lot of convincing. And today we're all very happy we have these data. So I don't think it's the kind of either-or situation as you just described, Don.
Rima?
I thought I said we had
Cindy,
to do both.
and then the back microphone. Rima?
Well, I think I have a challenge, certainly a question for the panel. My question comes both from what you said, Don, and from what you said, Ilona. And it's really, are we done? Are we finished? Do we really need funding for health literacy? Or do we need funding to take health literacy insights and reinfuse health communication with our insights from health literacy? Bring our insights of health literacy into health education programs, really good, solid programs, which has a very good evaluation track record, or health promotion programs. Do we need more health literacy work? Maybe the field is done. After all, the field began with the question of, oh my goodness, we know what the literacy skills are of the public. We now know that information in more than 30 industrialized nations. The next question was, are there health implications? We've answered that question. Yes, there are health implications. And it's well documented, the research is solid. The next question is, are the materials and information that we offer to the public accessible? The answer to that, with over 3,000 studies, is no. We have done poorly designed information efforts, whether it's on email or whether it's on the website or whether it's in print. We have that information well at hand. We know the health literacy skills of people in more than a dozen industrialized nations. So my question is, are we finished? And do we then turn our attention to bringing the insights that we gleaned about the importance of literacy to health communication, to health promotion, to health education, and perhaps to system change?
Are we done, panel?
Yeah. I think we are not finished, because you see we are dealing with a concept which is not only complex but dynamic. We are not finished doing other epidemiological studies. We have to do that because the times they are changing, and we have to measure what are the effects of our interventions. I think I'm very much argue for monitoring. Like we have monitoring in other areas, we need monitoring concerning health literacy, because health literacy is a very important outcome of how our society is working. And if we like to change these things, we have to measure it. Like in every quality, if we don't measure it, we can't argue. And we have to see if there is change, if we can improve the health literacy of a hospital organization. And we have to show that by data. We cannot just talk about it or do it and not show it. I very much from an epidemiological perspective and a quality perspective would argue we need continuous measures of health literacy.
I mean, I'd just like to repeat what I said at the beginning of my presentation. I think there are three things that we need to do. One for me is to continue to work out what health literacy is. I take the point that it's a dynamic concept, but somewhere down the line we have to have a compelling argument about what it is and what it does. But the second point I made, we need to put into practice what we already know, and as you've explained, Rim, we already know a lot. And I do think knowledge transfer is an absolutely fundamental element of what comes next. And the third area is about improving measurement and about using measurement in the kind of creative ways in which we've just been discussing and Juergen was advocating for.
I'd just like to add the dimension that we've been grappling with, and I started my talk with, is we know a lot, but it doesn't get done. It doesn't get done because we don't get the money to do it and bring it to scale. Why do we not get the money to do it, to bring it to scale, is because we don't get the political support, which is why we don't have the money. So I think one of the things we are grappling with is what kind of arguments and what kind of data do we need in order to be able to get different types of political funding decisions. So I think that's where we are, and that's why in terms of our starting point about health literacy, are we done or not, was can we find a measure that can help us in our political arguments, that we can say low health literacy costs X, for example, that people with higher health literacy will use the health system better. One of my discussions on health literacy in Europe with insurance companies is a fear of health literate people because they are fearful that they will use the health system more. So one of the things is we have to have data to show either the one or the other, and if they use it more, do they use it better? You know, what do I know? But I think that is the focus, because the tragedy, as I said, of our society, some of the most developed societies in the world, in the year 2012, with all the knowledge on health education, communication, health promotion, you name it, that we have not been able to make better advances in relation to population health. And for me, health literacy, the measurement of health literacy as an outcome, is a tool to move further in that direction. If we are to find out it's a tool that won't help us, then, you know, bad luck. But I'm willing to try.
Okay. So we have Cindy.
Can I come in for a bit of debate on that? Do you mind? I want to. I suppose I just want to. I agree with absolutely everything that Ilona says because I always do. But I mean, I think it's not right to say that there's not been advances in population health. The world over, there have been advances in population health. Oh, wait. But it's not. But that's not been accompanied by advances in equity in health. And one of the reasons why I very deliberately asked Juergen whether they'd started to explore this is that I actually think there's something in what we're talking about in health literacy that might be really useful, both in the discourse it prompts about the way the healthcare system works and in the approach that it promotes in terms of empowering individuals that really might make a difference in both advancing population health and improving equity. And that's all I wanted to say by way of refinement.
Totally.
So harmony at last at the front table. So we've got a couple of things to achieve here in the waning minutes of this meeting. I want to hear from Cindy. I've got 2 comments at the back. And I also need some much more specific commentary about how to further this international dialogue that was one of the questions that we started with. We had some suggestions about international working groups, about bilateral coming together, but if people have thoughts on that specific issue, I'd like to, before we adjourn, have some specific commentary on that specific sort of issue. Cindy.
Numerous comments that have been made on this panel and throughout the day made me think, where to take this question, where do we go next, really to heart. And so one of the comments was Don's comment about health literacy isn't a verb, and I absolutely agree with that. I talk about addressing health literacy, but I think, and it also brings me to a point which is a number of the speakers today implied that health literacy was an add-on activity. So it was like, another thing to do. And I would suggest that health literacy is evolving to be much more of an adjective. So we talk about being a health literate organization, doing health literate health promotion, doing health literate patient safety, that all of the stuff that we already do has to be done in a health literate manner. So we're talking about doing things differently and not about doing an additional thing. I think that Nicola, when she took up her crosswalk of the standards and said, I'm finding things that these organizations are already required to do and tagging them to health literacy. That's, I think, catching the moving train. There's a big patient safety initiative. Get on that train, think about what does that mean to do that in a more health literate fashion. I also, there was a last comment here that touched on something that I think has been largely absent from the discussion today so far, which is about incentives and alignment. And I would give an example of hospital readmissions in the United States. So back 7 years ago, my agency, the U.S. Agency for Healthcare Research and Quality, sponsored a study to look at a new way of doing hospital discharge, scrapping the old system, really building it from the ground up. What should that look like in a health literate manner? And did a randomized controlled trial, great results, reduced hospital reutilization by 30%. Was everybody knocking down the door in the hospitals asking, how do I reduce my people coming back to my hospital and bringing in revenue? No. Until we've now having a change in the payment incentives by the government agency, the Centers for Medicaid and Medicare, about how they reimburse for readmissions. All of a sudden, there's a huge uptake of interest on how to do this differently. But still, as my boss used to say, I can pay my son to get good grades at school, but if he doesn't know how to get good grades at school, he's still not going to be able to get that incentive. So we need to be focusing on the tools to help these organizations implement these kind of health literate strategies. Finally, I wanted to make a comment about measurement, which we have come to time and time again. One comment is that I'm a little nervous about the population-based, national, international surveys of health literacy as a measure of how good we are doing in the field of health literacy for two reasons. One is about the sensitivity of the measure. A colleague of ours who was advising the government in Singapore emailed several of us saying, look, I'm trying to help them, and they wanted something that they can use after a couple of years to see whether or not they are making any progress. And I don't think any of the measures, even if you're talking about the TOEFL or the RELM or other kind of more granular measures, are going to have that kind of sensitivity. The other reason why I'm worried about that as being our measure of success is when we talk about the health literacy equation, we talk about the capabilities and abilities of individuals on one part, and then we talk about what are the demands and complexities of the health system. And we can be successful even if we never change, and I'm not saying that we shouldn't strive to change and increase people's abilities and capabilities, but even if that stays static, we can achieve success if we've reduced the demands and helped them to be able to navigate, access, understand information. So thinking about measurement, I think we have a new challenge in trying to give people those kind of tools. And finally, I wanted to throw my hat in with Juergen when he mentioned measures of the attributes of a health literate organization. Again, trying to think through what kind of tool for monitoring can we give organizations that, yes, you're on the right track, you've made progress, et cetera. So I invite anyone else who's also interested in thinking a little further in that vein to contact me, and I'd love to bat some ideas around.
Great. Any response there? I think, well, I'll respond. I think in my other life, as part of the Measurement Application Partnership advising HHS on use of quality measures for incentives in their various programs, the topic of health literacy has already come up in terms of being included. Secondly, the recent Institute of Medicine report on the learning healthcare system, which is basically about performance and not about health literacy, now includes several references to health literacy. And there's a job to be done in terms of embedding that into the main line of policy development, the concept of health literacy, into the development of many policy approaches that are around the use of information technology and care delivery and so on and so forth. I think there are a lot of opportunities that once we educate people beyond this core of folks, researchers and experts, to others who are involved in those things, to begin to broaden the impact of this concept in many other policy initiatives. So my own personal addition to the conversation. Ilona?
Just to say there are many opportunities to, of course, link it to existing programs. I'm thinking of the health promoting school, where we at one time defined the characteristics of what defines a health promoting school. And possibly one could link, one could first of all revisit those characteristics and add some of those health literacy dimensions to them, even though I think indirectly they're there already, but maybe, as you say, they need to be more explicit. But on the other hand, one could take Juergen's idea of the PISA-like studies, and one could start comparing schools, and then one could perhaps see whether those schools that fulfill the health promoting schools criteria actually have more health literate students, more health literate teachers perhaps, or more health literate directors. So, I mean, you can think that through, and you can then use tools that have started to be developed and audits that help people self-assess. You can actually build a very composite program around that with the support of existing networks, be it the health promoting hospitals, the schools, the cities, or whatever. And that could be another action proposal to actually go to existing networks and say, we could together sort of build that interface.
That working across silos within each country is a tremendous opportunity for policymakers. Go ahead.
Just ad hoc to this together, you see there's now quite an interest in the health behavior in school-age children consortium to take a measure of health literacy into their measurement tool, into their instrument. And I think that will be a very interesting opportunity, and we are working on that. Therefore, we did this study on the adolescents to develop a measure which is useful for adolescents, which can be integrated there. So there are possibilities. And of course, you see your two other arguments, I cannot fully agree. Of course, we have to work on the sensitivity on the measure. And of course, measuring always is a risk, but I think we have to take this risk if we want to learn. And just saying we better don't measure because it might be misinterpreted, I think that's not a good strategy to go forward. And the second thing, of course, you see the measure we are using is a relative measure. If, as you said, the demands of system change, the people will feel different how dealing with specific tasks, and their health literacy will rise in the measure, you see? Because that cannot be an absolute measure. It's a measure towards the system. How difficult is it in a certain system, and how much competence you need in a certain system to do something. Yeah? I'm very much with you. We have to work much more on the other side and to improve systems, to make systems more user-friendly, more readable. That's, I think, a very, very effective and cost-effective strategy we should take, and in all settings.
So we've got, I think, 4 people. Was that right? 3 back there and 1 up here. Is that right? 3 of you there? So I think that's going to have to be our final comments. So I'm going to go to you. You've been here a long time, so please.
Okay, well, first I need to say that I am totally exhausted. I don't know if anybody else is, but I felt compelled to get my final comments on the record, I guess, as George and Ruth have said, so I'm going to just go ahead.
Excellent.
I came to this roundtable in particular, because I feel like we have a lot to learn from the work that's done internationally around health literacy. I also think we can go back in history and learn a lot from the early years of health literacy in terms of, you can't do maternal child health without doing literacy work. And so this is all work that's, taken place internationally and in developing countries. So I guess I have suggestions for what to do. I'd like to hear in the next roundtable or as a next step more from developing countries. I think that would be a very important thing. Also, in terms of U.S. base, I think we have a lot to learn. We do know a lot, and it's around kind of getting that out. But there are a lot of partners out there, and learning from the cultural competency community. I guess we can't separate culture, language, and health literacy. And I'd like to hear a lot more about that. And again, learn from the cultural competency folks, have done research in that area, learn from folks in the field doing interpreting, community health workers. I just think that these are voices that are missing, and so I'd like to hear these voices, cultural brokers, etc. The other point I get, is education. Also, I think we have a lot to learn from the education field. We did have, an expert educator on the panel, which was great. But I'd like to hear a lot more from the adult literacy and education field, from learning from adult learning theory. And I guess that brings me to my final point, which is around health literacy as a field itself. I feel very strongly about the word literacy connected to health and the work that health literacy people in the field do, because literacy is coming from, I guess, critical literacy and critical adult learning theory, which is all about, empowerment, and that health literacy is really not only a systems issue, but it's a patient rights issue, and I feel like the Affordable Care Act is kind of starting to say that. So it's very important to me that we keep health literacy together and that those two fields work together.
Thank you very much. Briefly, Andrew? We want to make our comments brief since we're now into the premium time, which is over our time.
I'm only carrying a piece of paper to look important. Andrew Pleasant, Institute of Medicine Roundtable member. I clearly agree with Don on the need for a conceptual framework, and I think there's a reason why we actually do need to agree on this. The field of health literacy would not fare very well in a systematic review from the Cochrane perspective. Research to policy research on that process will make it very clear that if you want to get in the policy door, it takes a solid evidence base to get in the door, and then the stories will win the hearts and minds. We don't have that solid of an evidence base yet, mainly because the methodology we have been inconsistently applied and they don't agree on the fundamentals. The other problem we face as a field moving forward is most of the studies have been conducted from a deficit model. We know very well what happens when health literacy isn't present. We are nowhere as close to sanguine as what happens when health literacy is present and how people actually use it. Rima often says that there's a critical moment of transition from learning to read to reading to learn. And in terms of whether it's a verb or not, to me, reading to learn is in fact an action. So I would say that's still an open question. And to actually answer your question specifically, I think now is absolutely the time to create an international organization of health literacy. Count me in. I've had this idea in my own mind for over a year. The US has resisted a nationwide organization. We seem to prefer the state level, which is fine, but it seems incomplete. So I think that's a fantastic next step. I hope we all agree.
Thank you. We're going to take two more brief comments, and then we have a time limit on what we have to adjourn. So.
Okay. Hi, I'm Lisa Bernstein from the What to Expect Foundation. And I've been working in developing nations that don't have or are building healthcare systems, and I see us exporting our dysfunction, creating the same kind of systemic power paradigm where there's a doctor frequently trained here or trained in a European country who's coming home to his home country with this great knowledge and building the same systems over again. So I really hope that this will grow and include the systems building for developing nations, because it's heartbreaking to watch, and we should get ahead of that curve instead of letting it continue.
Thank you for that very important reminder. Really appreciate that. And your last comment.
My name is Sofia Leticia Morales. I'm from the Pan American Health Organization, that is the regional office of the World Health Organization for the Americas, US, Canada, Latin America, and the Caribbean. Health literacy is an outcome, and it's also a political goal in this in a modern democracy. And I will say it's also a challenge when we set that goal into the health in all policy. So my question is, how, if we understand the political process as an awakening process and conscientization process, how can we work in this, the health literacy as an outcome? What is the best strategy to work with politicians, with the parliament, with the other ministers? Because in talking about health in all policies, we need to start also at that dimension, as well as, of course, at the population strategies and health promotion that we already had, the network of health promoting schools, health promoting municipalities. We work with the mayors, but we wanted to work in this process of conscientization and awakening with the other ministers, with the presidents, how to really understand the outcome of health in all policies, but also the outcome of health literacy.
Thank you so much. Any concluding comments from the panel before we're done here?
I think we're all exhausted.
Okay. I would like to ask you to join me in thanking this panel. So we've heard a lot today, and I think several have said they're exhausted. I'm tired too. And I think we've heard, I'm particularly grateful to this last panel for very eloquently capturing a number of key issues and next steps. We don't have agreement on whether we should continue to come to a common agreement on the definition, but we had a lot of good debate and understanding of the arguments, both pro and con, with respect to that. We certainly heard a lot of practical issues from the different countries in terms of moving health literacy forward, and we heard some of the issues related to advancing the science. I would like to go into a much longer summary, but I can't, and I won't. And I will say that we will produce a summary of the discussion. We will circulate some of the materials that several have promised to send to Lila and that we'll send to the members of the conference. We will make available the paper by Andrew Pleasant on the International. That's available on the website. And we will look forward to the Roundtable has sessions that are also closed where we will have a conversation about what we heard and what next steps we as a Roundtable in particular should take in response to this discussion. I hope and expect that everybody who's been here today from the different countries and from the U.S. as well will think about that same question and acting on some of the suggestions that, excellent suggestions that we've had. So I want to thank all of you for participating and actively making comments. Again, Lila and Angela for the just outstanding support. The New York Academy of Medicine, Joe Ivey, for hosting us. And if there's anybody else I've forgotten, I don't know who it is. But certainly thank you for all, especially those who have traveled from some distance to be with us today. We really appreciate that. Thank you all to all those who joined on the web too. We're adjourned.